Myocarditis. Myo means muscles. Card means heart. Itis means inflammation. It's usually due to viral infection and prognosis is good. With good management, patients recover without any complication. This is endocardium. This is endocardium of the heart. This is pericardium or epicardium of the heart. And this is myocardium. This is myocardium and its inflammation is called myocarditis. Causes of myocarditis. There are two sets of causes. These are infective causes and these are non-infective causes. Prognosis in infective causes is better, and usually patients who have non-infective myocarditis will have complications like dilated cardiomyopathy. And in infections, viral infection is commonest. Coxsackie A and B, rubella, varicella, influenza, herpes, COVID-19, recent addition. Bacterial causes: rheumatic fever, diphtheria, brucellosis, legionella, meningococcus, clostridial infection, and tuberculosis. In diphtheria and clostridial infection is due to toxin. Parasitic infections: trypanosomiasis, Chagas disease, common in South American and African countries, toxoplasmosis, hereditary disease, and schistosomiasis. Fungal infection: aspergillosis, actinomycosis, candidiasis, and mucormycosis. Rickettsial infection: Q fever and scrub typhus. Metabolic diseases: hyper and hypothyroidism and pheochromocytoma. Autoimmune diseases: rheumatoid arthritis, SLE, and scleroderma. Cardiotoxicity: it's alcohol is very common, and alcohol and cocaine. Irradiation to thorax: chloroquine, cyclophosphamide, chloramphenicol, and hemochromatosis. Nutritional: beriberi, kwashiorkor, chronic calcium and magnesium deficiency, granulomatous sarcoidosis, giant cell myocarditis, and disorder of metabolism, Fabry disease, and glycogen storage disease. Clinical features: fever, chest pain, dyspnea, and features of respiratory illness. Usually patients are healthy and adults. Symptoms and signs of heart failure. You can see left ventricle is big and the residual volume is higher than normal. You can see this is normal heart. Myocardium is normal. Here you can see myocardium is dilated and end-diastolic volume is bigger than normal, higher than normal, and so end-diastolic pressure will increase, and this pressure will be transmitted to left atrium and from left atrium to pulmonary vein and arteries, and patient may have cramps and dyspnea, and patient can have arrhythmia and conduction disturbances also because ventricle and atria is dilated, and there are patients who can present very fast. This is called fulminant myocarditis, and in fulminant myocarditis uh, patient will have history of respiratory illness, and patient will present with cardiogenic shock and multi-organ failure. Cardiac output is so low that kidney and other organs like liver has start failing. And clinical features of primary disease. We have seen there are two types of myocarditis: infective and non-infective. In non-infective patients, patient will have features of clinical features of primary diseases. Investigations: WBC count, ESR, C-reactive protein, creatinine phosphokinase, and troponin level. These all levels will be elevated, and troponin is very specific because it's found only in heart. So elevated troponin level will be suggestive of myocarditis. ECG, we see sinus tachycardia because heart is failing, so there will be sinus tachycardia, and there will be diffuse ST segment elevation. This we have seen in pericarditis also. Diffuse means in almost all leads except AVR. AVR will have just reverse changes. ST segment depression, and in chest X-ray there will be cardiac dilatation, cardiomegaly, and features of pulmonary congestion. Echocardiogram is very helpful, and during echo we will see this myocardium will be thinned out, and this will contract poorly, and this is poor contraction of this myocardium is suggestive of myocarditis, and there will be ventricular dilatation. You see this is normal ventricle and normal myocardium. See this myocardium is thicker, and this end-diastolic volume is less than this. You see this ventricle, left ventricle has dilated too much. And CT and MRI scan, we will see cardiomegaly, and cardiac catheterization will measure pressure in different chambers of the heart, and left ventricular pressure will be higher because left ventricular end diastolic volume is more, so end diastolic pressure will be higher. Complications: dilated cardiomyopathy, especially in non-infective myocarditis. In infective myocarditis also can have dilated cardiomyopathy, but in non-infective myocarditis, dilated cardiomyopathy is usual. And in heart failure, both sets of patients, the heart failure, especially left ventricular failure, arrhythmia, and conduction disturbances. Treatment: the disease is usually due to virus, and it is self-limiting. You have to just buy time. You should prevent patients from going in complication. Patients should not face your heart failure. Patients should not go in fulminant myocarditis and multi-organ failure. Antivirus may have some role, and supportive care is important. Supportive care, you should limit physical activity of the patient because heart disease. Antiviral, antibiotics, especially in myocarditis of bacterial origin. You should give oxygen because patient has heart failure and patient has hypoxia. So you should give oxygen. You should give NSAID because myocarditis is inflammation of the heart. It will reduce inflammation, and it will reduce chest pain of the patient. Steroids sometimes, especially in non-infective causes like SLE and rheumatoid arthritis. Extracorporeal membrane oxygenator (ECMO). ECMO will help the patient. Patient can have some time. Suppose patient is not recovering and patient is waiting for heart transplant. ECMO will give some time. ECMO will keep patient alive. This is ECMO. Here blood is oxygenated, and this is a motor, and this motor will get blood from vein and artery, and it will pump blood to the to heart. Through vein it will pump blood, oxygenated blood, to the heart, and this ECMO machine will keep patients alive till heart is available for transplant. Left ventricular assist device, this is very important, and this has almost the same role because lung is healthy. So just this is motor, this is LVAD's motor, and this motor will get blood from left ventricle, and this motor will pump blood to aorta. So and a patient who is not fit for heart transplant can survive and can live a healthy life with LVADs. Management of heart failure, it's universal everywhere. Either heart failure is due to myocarditis, cardiomyopathy, or myocardial infarction. Management is similar everywhere, and your heart is like this horse. This horse weak, so it will not work. Uh, and similar is, and your heart is weak, so you have to give inotropic support to the heart so that force of contraction can increase and it can pump more blood and it can supply more oxygen to peripheries, to systems. And for to increase inotropic support, what do we use? We use digoxin, dopamine, dopamine, milrinone, or combination of these drugs. It will increase force of contraction and cardiac output. And during myocarditis and cardiac failure, there is usually tachycardia, and tachycardia will increase oxygen consumption of the heart, so you should use beta blockers. And during heart failure, you have to act at three levels. At heart, you have to use inotropic support, you should reduce preload, and you should reduce afterload of the heart. You see, this man is obese and preload is too much. So this horse is even not able to stand erect. So reduce preload. Reduce preload, horse will start working again. And what is preload? Preload is ventricular end diastolic volume or pressure. So you should try to reduce ventricular end diastolic volume. If you are not able to reduce it, at least you should not increase preload on the heart by giving excessive fluid and blood. And afterload, what is afterload? Afterload is systemic vascular resistance and blood pressure of the patient. During myocarditis, uh, try to reduce systemic vascular resistance and blood pressure. It should not be too much. And how do you decrease systemic vascular resistance? By using vasodilators and AAC inhibitors. So you must see this angle. More you increase this angle, horse will have to uh, work more. So you should try to for effective working of this horse, you should try to reduce angle. This angle, you should reduce angle. Heart will This horse will work better, and this angle is equivalent to systemic vascular resistance. As you increase this angle, as you increase systemic vascular resistance, heart will you are just strangulating the heart. I have seen these days these days people are using multiple vasopressors. They use first start using NORAD, then they start vasopressors, uh, vasopressin and adrenaline. You are strangulating heart of the patient. You should just use one drug and in minimal required concentration. Don't use three drugs, two drugs, and in high concentration. Sup- Support heart, reduce preload, or in hypovolemic shock, increase preload, support heart, this and try to reduce afterload. Don't increase afterload by giving three vasopressors, two vasopressors, and in excessive doses. Never do it. You are strangulating normal heart or diseased heart, and you are killing your patient.